we'll get started. So good afternoon, everybody. Thank you so much for joining the Collaborative's public webinar series and for your flexibility in accommodating a new date for this conversation. We are so excited to dedicate a bit of time to talking about the California Advancing and Innovating Medi-Cal initiative, also known as CalAIM. And I know this probably isn't the first time you may have seen CalAIM surface as an agenda item at the collaborative, but given how big and bold and detailed and exciting this initiative is, we thought it might be helpful to host a quick crash course. So we're taking a bit of a step back, actually, to look at CalAIM from that 30,000-foot level. And we've asked our panelists to keep the conversation light and to avoid acronyms whenever possible, use plain language. And the goal really is to break down what is a very policy wonky topic and have everyone be able to walk away and feel like they can explain CalAIM to their family members, to their friends, colleagues, maybe a stranger you see at the grocery store. And we've split today's program into three somewhat distinct sections. So we'll start off by hearing from our esteemed colleagues at the California Department of Healthcare Services, who will provide a general overview of CalAIM and discuss some key initiative components and provisions. And after that, we'll turn to a panel conversation to hear kind of diverse perspective and considerations. And finally, the third component of today's program is hearing from you, the audience. So we've set aside about 20 to 25 minutes for Q&A, and I encourage you to engage throughout the presentations today. You can use chat or the Q&A feature. And as a reminder, please remember to stay courteous. Remember that we're all learning together and that this is a collaborative environment. And with that, it is my pleasure to introduce Bambi Cisneros, Assistant Deputy Director of Healthcare Delivery Systems at the California Department of Healthcare Services.
Great, thank you so much, Maria, and thanks for having me here it's afternoon, so thanks for having me here this afternoon. Wanted to see if, I know Anastasia sent a message if she was able to maybe have a panel listening, so I just wanted to make sure that she was able to join.
She's here, Bambi, so I'll move her over. I think I have.
Okay, great. Okay, great. And did we send the slides in advance?
Yes.
Or do we have slides? Okay, okay.
I'm not seeing Anastasia, so I hope she may have hopped off and is rejoining, but I'm happy to share the slides, Bambi.
Okay, great. Thank you very much. Okay, thanks, Anastasia. Just wanted to make sure you were taken care of. Great. All right, thanks again, everyone. Thanks for having me here today. My name is Bambi Cisneros, and I'm the Assistant Deputy Director for Managed Care under our Healthcare Delivery Systems programs. And I work very closely with our managed care divisions to implement some of these very exciting initiatives as part of CalAIM. So I wanted to talk about some of these initiatives with you. And so for this presentation, I want to provide general information on CalAIM, and specifically the components that impact our organization and members. So specifically, enhanced care management, or ECM, community supports, and a dabble of population health management. There's quite a number of things happening in our Medi-Cal program right now, which is exciting, but also would be good to connect, so that we have a base level understanding as we embark on all of these initiatives from 2022 and beyond. And so we can go on to the next slide, please. So we are very excited to have secured federal approval from CMS to implement CalAIM, which are primarily through the 1115 and 1915B waivers. And so as CalAIM, and we'll kind of talk about in later slides, as we shift Medi-Cal to a more population health approach, as we'll talk about here today, which was first included in the Medi-Cal 2020 Section 1115 demonstration, to now a statewide level that prioritizes prevention and addresses social drivers of health. And collectively, the CalAIM Section 1115 demonstration and CalAIM Section 1915B waiver, along with our Medi-Cal state plan and also contractual requirements, will enable the department to fully execute CalAIM initiatives, which will really allow us to provide person-centered care and integrate coordination across physical health, behavioral health, and local service providers. And so just wanted to bring us back to one of the core principles of CalAIM, which is really to standardize and align across programs. And by transitioning all 4 of our delivery systems, so we have Medi-Cal managed care, we have dental managed care, our specialty mental health services program, and our drug Medi-Cal organized delivery system under one 1915B waiver. This will really allow us to streamline our policies all across the board. Okay, we can go on to the next slide, please. So as I had just mentioned, CalAIM is transformative, it's bold, it's exciting, and we are really excited to undertake all of these initiatives because it's the first time that Medi-Cal really is kind of transitioning away from just looking at the person's physical health and really looking at the whole person. And so the idea of CalAIM is that we would look at the whole person, we would engage providers that can provide services to treat the whole person. So it's not just the member's primary care provider or specialist, for example. And then this is like, it takes a village, right? So we are expanding community supports and looking at community engagement because there are various types of providers that managed care plans may have not traditionally used to provide these kinds of wraparound services that we are really pulling into CalAIM. And so again, one of the key goals is to make the best use of our partners and resources because this is a new world and we're very excited to go on that journey. We can go to the next slide, please. Okay, so here on the slide, we have several initiatives for 2023 and specifically that impact dual eligible members. So we have population health management, which is going live in Medi-Cal managed care. We are also transitioning the ECM or enhanced care management population of focus specifically for long-term care. And these are specific to individuals at risk for institutionalization who are eligible for long-term care services, as well as nursing facility residents transitioning to the community. Another component of CalAIM going live in 2023 is the statewide carve-in of long-term care into managed care. Today, the long-term care services are carved into the COES counties and CCI counties. And by 2023, the department is intending to do this statewide carve out for all of the other kind of remaining counties. Also, statewide mandatory Medi-Cal managed care for dual eligibles. And then CalMediConnect will be ending at the end of this year, and exclusively aligned enrollment. Dual special needs plans will be launched in the CCI counties. And one thing I wanted to just mention on the slide is that we are still working out how population health management and care management will work for duals, especially those in D-SNPs, as well as digging into the long-term care populations of focus. I know we're having continued stakeholder engagement there. So what I would say on that is more to come on these policies. Okay, we can go on to the next slide, please. Okay, so population health management. So population health management, the program is focused on the managed care plans and how they approach population health management. And so the conceptual framework really is that there is data aggregation that takes place from the various sources, referrals, assessments, et cetera. And then the plan would then use that data to then do a risk stratification and across their population, and then assign those populations a certain risk tier or risk level. And then those risk tiers would then inform what type of care management program the member would need, or the services that, or perhaps the services that would apply to the whole population, such as basic population health management, wellness and prevention services, and transitional care. And so the goal of population health management is really to do this, bird's eye view, identifying the population at large and then kind of honing in on their specific members' needs, and doing this through care management, coordination, and care transitions. Next slide, please. So at the same time, the population health program is rolling out. The department is also implementing a statewide population health management service. And what that really does is designed to collect and integrate data at both the statewide and local level. And so the population health management service is to provide access to all of those different types of data to managed care plans, providers, counties, Medi-Cal members, and any other authorized users, so that they could have more timely and comprehensive understanding of the member's health history and needs. And the population health management program really is intended to help compare apples to apples and better understand population health trends and oversight. Because some plans may not do population health management today, and if they do, they have different methodologies. And so the idea is that we would standardize, again, here kind of across the board. And then the population health management service will be deployed in January 2023. And then, certain capabilities will be incrementally phased in. And so there is additional information on the specific, because this is a kind of a service or IT platform. So there's going to be additional information that the department will send out later this year in terms of the population health management service. So we talked a little bit about this as far as the population health management framework. And so being that it's, a managed care plan responsibility to look at their entire membership. And we have kind of, different segments or domains, so to speak. So the population needs assessment and population health management strategy, kind of on the bottom here, is really the mechanism by which each of the plans will identify and prioritize the health and social needs of their membership. And so the population needs assessment will support the plans developing an annual population health management strategy, which will replace the current population needs action plan starting in 2023. And we see the population needs assessment and population health management strategy to be foundational to each of the plans' work on population health management, because they do reflect the unique needs of each of their members, and as a group and as individually as well. And so kind of going at the, reading the chart from left to right. So here, another component of the population health framework is the gathering information stage. And here, what we're saying is that the department expects each plan to really gather and use a wide variety of data to conduct the population health management, including data that the plans have access to kind of within their own four walls, as well as externally generated information such as provider referrals, assessments, screening, et cetera. And so the idea is you can take all of this data from various sources, and then it'll kind of get you to better understand the risk. And so that the department expects each plan to have a population risk stratification approach. And we're really looking to the NCQA standards for those kind of required information that the population health management program should contain. And then once the population health management service is live, and then that service is kind of like an IT infrastructure, and it's really intended to support kind of gathering that information and kind of helping the decision making along. And then we have here providing services. And what this is based on the risk tiers that are assigned to the members, the plans would then offer supports and intervention that's specific to the members' needs. And so this includes basic population health management for all members, care management, which includes enhanced care management or complex care management for the highest needs and or like the medium rising risk members. And one thing I wanted to point out, because this is pretty heavy and there's a lot of details here, the department did issue and post the DHCS comprehensive quality strategy on our website. I'm happy to share the link to that if you are all interested, but it kind of dives into all of these kind of concepts in more detail. Okay, so we can go on to the next slide, please. Okay, so enhanced care management. So ECM is part of the plan's population health strategy that we just talked a little bit about. And this means focusing on preventative care to keep members healthy, assessing member risks and what they need to do on an ongoing basis, doing care coordination, and identifying and addressing social drivers of health. So that's what they do as part of their pop health strategy. And then ECM fits within that population health strategy. And it's really a community-based intensive program where the plan will contract with various types of providers to provide these high-touch services. And one thing I wanted to note is that ECM is really not intended for all members. It is, as it's really for the highest need and those needing the highest tier of care management. And so prior to CalAIM, there were 2 tiers of care or case management in Medi-Cal. We had basic case management, which was available to all individuals in the program if they need it. And then we had complex care management, which is for individuals who have more complex needs and need more care coordination. And now ECM is the third and top tier of that care management kind of structure. And it's really for the most complex individuals. And so to be eligible for ECM, the member must meet specific eligibility criteria. And we do have 7 mandatory target populations for which they would be good candidates for ECM. And then one of the principles of ECM is that there's one primary case manager that's coordinating across the system. And so I think having this one person coordinating those services will really kind of help bridge those silos between the members' physical health needs and their kind of wraparound needs, such as social health, social services, and behavioral health. And we also had linked on the slide, on the previous slide, a link to the ECM webpage and the ECM policy guide, which does have additional detail as well. Okay, so the implementation timeline. So we're very excited to have implemented ECM starting on January 1st, 2022. And we did this for certain populations of focus, so individuals and families experiencing homelessness, adult high utilizers, adults with SMI or SUD, and incarcerated population are transitioning to the community. And we did this for those populations in the 25 counties that previously had whole person care or health homes program members. And the reason we did this kind of phased approach is to allow plans to grow their networks and stand up processes such as data sharing agreements, referral mechanisms, developing care management platforms that would be shared across various entities, and really kind of allow the plans to stand those up while continuing the services for the existing whole person care and health homes members. And in July, this coming July, we will transition those same populations of focus in the non-whole person care and health homes counties. And then we're also gearing up for January 2023, where we will be implementing three populations of focus, which is the incarcerated, at risk for institutionalization and eligible for long-term care, and nursing facility residents transitioning to the community. And then finally, in July 2023, we will be transitioning children and youth, and there are current stakeholder efforts kind of in that space as well. And so I would say for the January 2023 implementation, we are continuing our stakeholder engagement, such as with this group, to really help inform the policy. And I do want to take the opportunity to thank you all for sharing your experiences and expertise with us as we work through the policy for our elderly population. So we can go on to the next slide. So here on this slide, we have kind of a snippet of what we had indicated in the ECM policy guide, and we referenced the page numbers here. And we just wanted to clarify some points here in that the ECM policy guide was developed ahead of when we first implemented in January 2022. So it says that, you know, there are some ECM eligibles and non-ECM eligibles here. And we just wanted to clarify that these policies apply to 2022 only, and that plans are required to offer ECM to all members if they meet the populations of focus. And that the requirement to offer ECM to all who meet the populations of focus criteria applies to dual eligible plan members, except if it's indicated as no on the right column here under ECM eligible. So CalMedi Connect, FIDE, SNPs, and PACE programs. And then, as we mentioned in the previous slide, the 2 long-term care focused populations of focus will be going live in 2023, and we're working through those. Okay. Next slide, please. Okay, so a little bit of a continuation where we grabbed kind of a screen print from the ECM policy guide here, and we just wanted to clarify, there are some, I don't know if carve-outs is the right word. So carve-outs where ECM is not the appropriate kind of program or service for members, and those members are those on 1915C waivers. And so the clarifying point we wanted to make here is that if those members are on a wait list for the 1915C waivers, they can be eligible for and receive ECM while they are on the wait list. And then another point of clarification is that members in the California Community Transitions Money Follows the Person program cannot also be enrolled in ECM at the same time. And the reason for that really is just that they have kind of their own care management protocols as well that's kind of intended to do something very similar to ECM. So we just wanted to make sure, no duplication, and of course we're using resources as efficiently as possible. Okay, we can move on to the next slide, please. Okay, so for community supports, just to take a step back on just some background on community supports. So in 2016, the Medicaid managed care final rule allowed us to provide services in lieu of services or settings that's covered under the Medicaid state plan. And so at that time, we were kind of considering them to be in lieu of services, which are alternative services to state plan benefits that are intended to help avoid or eliminate the need for higher level of care or more costly services in the future. And so what we proposed and were approved for by CMS are 14 in lieu of services, which are essentially wrap services. And so what we're doing here is taking social drivers to improve health and ultimately reducing the members' cost of care. And then the list of services are in the following slides and include paying for transitions from skilled nursing facilities and transitions to the community. And so as an example, for our aging population, it allows us to provide ECM as well as these wrap services that's needed to either keep the person out of the institution, or if they aren't in the institution and they choose to, it would allow them to transition safely back at home or an assisted living environment. And so in those instances, we would pay the wrap services within the residential care facility. Community supports also allows us to pay for home modifications if that is what is needed for the individual to be at home safely, as well as medically tailored meals. And so we have here like the 14 menu of approved community supports. So sorry, if I can just go back to the previous slide, because I think this one's a link. So linked here kind of within the purple box is a grid that shows, or a matrix that shows all of the various community supports that are offered by each of our managed care plans by county. And we do intend on updating this list with any changes to the plan offerings. And so wanted to provide this resource to you. Okay, we can go on to the next slide, please. Okay, so this is an example of one of the approved community supports, which is the community transition services or nursing facility transition to a home. And this is community support is really to help transition individuals from a licensed facility to keep them housed at home or in the community. And this service will cover non-recurring setup expenses such as security deposits for first month utilities and home modifications to ensure access and reasonable accommodations. And so for this particular community support, we will be implementing this in January 2023. Okay, next slide, please. Okay, we are also working on the long-term care managed care carve-in. And I kind of mentioned a little bit earlier that long-term care is really incorporated as part of the COES county plan model contracts, as well as in the coordinated care initiative counties. And so what the department is intending to do here, starting January 1, 2023, is really carving in long-term care to all of the other plan model types in the remaining counties. And so for this particular initiative, we do have, are having continued discussions with our stakeholders and do intend on providing updates at one of the monthly MLTSS duals integration stakeholder meetings as we kind of like work through this policy. Okay, so for the statewide mandatory Medi-Cal managed care, in the 1915D waiver that we've received approval, the department officially requested to continue mandatory enrollment in Medi-Cal managed care of dual eligibles in CCI and code counties, and to authorize mandatory enrollment in Medi-Cal managed care of dual eligibles in the remaining counties starting January 1, 2023. So today, duals are mandatorily enrolled in Medi-Cal managed care in 27 counties, while being voluntary in all other counties. And so starting in January 1, 2023, duals will be mandatorily enrolled in Medi-Cal managed care in the remaining 31 counties. Okay, on this slide here, we talk a little bit about excuse me, aligned enrollment. As we sunset CalMedi-Connect at the end of this year and move to the aligned enrollment model for January 2023, one of the lessons that we've learned is that integrated and coordinated care really yields better outcomes for our dual beneficiaries. Excuse me. And so aligned enrollment will really build on those successes in CalMedi-Connect. Excuse me. While I try to gather my voice, Anastasia, is there anything that you would add to these?
Yeah, thanks, Bambi. Just to add that we have a monthly stakeholder meeting on this topic, and so I know many of you have participated and joined that meeting, but again, we have, there's 12 matching plan counties that already have aligned enrollment. When someone selects a Medicare Advantage plan or a DSNP, then their Medi-Cal plan will automatically align to that same plan if there is an affiliated Medi-Cal plan. So of course, there are many Medicare plans that are not affiliated with a Medi-Cal plan in California. And so this aligned enrollment in these 12 counties is just when there is an affiliated Medi-Cal plan with the Medicare plan. And then, as Bambi said, we're going to be transitioning the CalMedi-Connect demonstration to an exclusively aligned enrollment process, which is very similar to CalMedi-Connect. And I think there's more on the next slide there. So an exclusively aligned enrollment DSNP is one that has many of the same features as CalMedi-Connect, but a DSNP is a contract between the state and the plan, and then the plan has a contract with CMS. CalMedi-Connect was a three-way contract. So anyway, there's so much technical stuff. I'm gonna not do a good job of staying at high level here, but I think the main gist of it is that exclusively aligned enrollment plans are very similar to CalMedi-Connect plans. And I'll hand it back to you, Bambi, if you want to keep going.
Thank you, Anastasia. Gosh, it's totally allergy season, so apologies for that. So I think what we're saying is aligned enrollment really intends to build on the success of CalMedi-Connect, and it sounds like there's just going to be continued stakeholder work in this space as we develop and implement these SNP aligned enrollment. Okay, so we can move on to the next slide. And the next slide, I think we talked a little bit about that.
Yeah, the key area just to emphasize is that any Medicare Advantage plan enrollment is voluntary. So sometimes when people hear Medi-Cal managed care mandatory for duals, that's on the Medi-Cal side, but on the Medicare side, it's always voluntary.
That's a good point of clarification, Anastasia. And so I think that takes me to the end of this presentation. We did share as part of the appendix kind of additional details more on the community supports and the listing of those 14 specific services. We want to provide this information to you. So, so if it's a good time to pause, I'll do so and see if there are questions or discussion items for us.
Maria, you're on mute.
Thank you. And I'm sorry, I'm struggling without my colleague who usually does all the technical stuff behind the scenes, and she's on vacation, which is well deserved. So I actually would encourage our audience members who have questions to use the chat, use the Q&A. We're gonna actually save about last 30 minutes or so for discussion. Bambi, Anastasia, I hope you can hang on with us as we get through kind of the panel conversation. You're able to stay for the full 90 minutes. That would be wonderful. And at this time, I think I'm gonna pivot to Athena and ask our panelist members to start turning on their cameras so we can see them as well.
Great, thank you, and thank you, DHCS, for those quick updates. I know a very complicated subject, trying to hit the high points. And so we have sort of a reactor panel here next. I'm really excited to have some folks that have definitely been following this from different perspectives and can provide an overview of sort of what their interpretations are of where CalAIM is going and some of the things that need to happen along the way. So first, we will have Tiffany Wynn-Cho, who's a senior staff attorney at Justice and Aging. She joined the healthcare team at Justice and Aging in 2021 and is based in the Bay Area. Her work is focused on lower income older adults who are dually eligible for Medicare and Medicaid benefits in California. Following Tiffany, we have Selena Escobar, who is Program Director of Special Programs at Anthem Health Plan. Prior to being in Anthem, she was the LTSS Manager of LTSS at Public Programs and Operations at HealthNet, and she also serves on the Board for Resources for the Independence in Central Valley. And then we have Anwar Zahid, Vice President of Long-Term Services and Supports of the Partners in Care Foundation. He works to align social and health care to address the social determinants of health and equity disparities affecting diverse, underserved, and vulnerable populations of all ages. And then last but not least, we have Jack Daly, Director of Policy and Training at the Legal Aid Society of San Diego, where he serves as the HCA Coordinator for the Consumer Center for Health Education and Advocacy, which assists low-income and disabled individuals getting access to health coverage and ensures those with coverage can access needed treatments and services. So very excited to have this great group of folks. As you can tell from my long descriptions, they are very qualified, and we're excited to hear from them. So Tiffany, I will hand it off to you to start.
Hey, hi everyone. Thank you for the introduction. So first, thank you for the invitation to speak on this panel. I'm going to provide a broad, high-level overview of CalAIM and what it means, what CalAIM intends to improve, and its potential to transform really Medi-Cal for the better and, improve how that system really operates today for low-income older adults and people with disabilities. So first I thought it would be helpful to describe how Medi-Cal exists today. Medi-Cal is very broad. It is far-reaching. It offers a really wide range of healthcare and other services to almost 14 million low-income Californians. That is a very large portion of California as a whole. And Medi-Cal coverage itself includes primary care, specialty care. It has behavioral health for people with mild to moderate needs, as well as those that need more intensive care. It covers skilled nursing facility, dental benefits, as well as, home and community-based services, those services that really help someone remain at home as well. So it's really broad. But part of how Medi-Cal operates with all of its broad range of services is that the system that delivers these services is also really complex. It is fragmented. Medi-Cal can be complex to not navigate itself. Medical providers or those home and community-based providers often operate in their own frame. They are siloed. There isn't always a lot of opportunity to interact with each other or to communicate with each other and really provide care and coordinate care for a single individual. So part of that complexity is due to the fact that the care and services that Medi-Cal provides is delivered through different systems. So there is Medi-Cal benefits that are delivered through a managed care plan, and then there are those that are delivered in the fee-for-service system. For example, primary and specialty care are delivered through your managed care plan. But for some Medi-Cal beneficiaries, you might get long-term care delivered in the fee-for-service delivery system. So these systems, they operate very differently. Because of that, it is very difficult to coordinate care. I feel that we have seen that in many of our counties. But yet, because these services that Medi-Cal provides, they're really critical to helping a person remain healthy. CalAIM really represents an opportunity to pull these fragmented systems together and create channels of communication and responsibility between managed care providers or fee-for-service providers, and provide some clearly defined roles and responsibilities so that we can better improve care and coordination under CalAIM. And not to mention, if you have Medicare benefits, the system is even more complex because both providers and individuals are navigating two wholly separate forms of health insurance, each of which have their own rules and systems for how each insurance operates. So under CalAIM, this is an opportunity to pull together these different systems to streamline benefits for dual eligibles that have Medicare and Medi-Cal, and improve both communication and coordination. So CalAIM really does provide uniformity across the delivery system. Right now, how you receive care might depend on the county that you live in. Like Bambi noted, long-term care will become the responsibility of Medi-Cal managed care plans statewide in 2023. But right now, long-term care is already the responsibility of managed care plans in 7 counties. So there is discrepancy on how a person might receive their care depending on the county that they live in. And similarly, all dual eligibles will also join a Medi-Cal managed care plan in 2023, whereas right now, some duals are subject to Medi-Cal managed care plans in certain counties, but others are not. So CalAIM kind of pulls together not pulls together, I guess it's not the word, but really provides uniformity and standardizes the delivery systems so that it's not so dependent on the county that you live in and where you reside, which that provides a lot of confusion. A person in Alameda County could be subject to different rules than someone that lives in Santa Clara County. That really, those counties are not even that far apart. So the move to managed care statewide really is a mechanism to better coordinate care amongst providers and to deliver specific services, such as that enhanced care management and the community supports. Both of these components really have great potential to bridge gaps in care that exist right now. Specifically, they can reach older adults who have high needs or residents in a nursing facility that want to transition back to their community. As Bambi noted earlier, these services, enhanced care management and community supports, are only available to beneficiaries that are in Medi-Cal managed care plans. Specifically, if these two components work together, they can provide care and bridge gaps because community supports and ECM will identify people that qualify for these services and help provide them. So for example, I know community supports are very similar to home and community-based services. And those are services and supports, those wraparound services that can help a person remain at home and avoid a nursing facility. Home modifications, handrails, or support bars that are needed to help someone live at home. Medi-Cal provides some of these services through home and community-based services, but home and community-based services are not available in every county in California. So community supports, because they are similar to these important home and community-based services, they can really bridge the gaps when home and community-based services are not available in that county. So overall, I think CalAIM really provides a broad framework to coordinate care. It pulls people together, and it really can improve communication, identify the areas of responsibility between managed care providers, the fee-for-service system, to provide that important person-centered care that will really help people remain healthy and utilize all the important benefits that Medi-Cal can provide as well. Thank you.
Great, thank you so much, Selena.
Good afternoon, thank you. All right, happy Monday, everyone. So I wanted to share a little bit from a Medi-Cal managed care health plan perspective and offer some insight as to what CalAIM looks for us. Leading up to CalAIM, managed care plans had participated and still are participating in the coordinated care initiative. There were lots of lessons learned and best practices that were identified. And at the same time, hand in hand, we have created and operationalized other pilots such as health homes programs, whole person care. Other unique pilots to some of the managed care plans include home delivered meals, medically tailored meals, flex funds for things that will help an individual pay for a security deposit or housing deposits. As a result of these programs and pilots, stakeholders such as yourselves and plans have identified trends and goals to work towards, such as communications and proper communications, outreach and education, looking at better streamlining data and information exchange, and making incentive funds available that focus on capacity and infrastructure. So CalAIM truly is exciting. The expectation with CalAIM is that it will get us all to a place where service delivery is more streamlined and those goals that I mentioned over the course of several years are achieved. Programs and benefits under CalAIM, and you've heard a little bit about this already by our presenters, that support older adults include enhanced care management. This is such a great benefit. Intensive one-on-one in-person care management. The ECM care coordinators will work one-on-one with our members to help ensure they get the care that they need, the care that's specific to them. The ECM care coordinator will provide the necessary outreach, answer individual questions, and are there to provide the health education that is, again, specific to the unique needs of that individual or of that member. The care coordinator will also connect to, and you heard a little bit about, community services, which are social wraparound community-based type services, and vice versa as well, right? Our community supports teams internally within the plans are also connecting individuals to ECM, and so vice versa, there is connection there. Currently, as well as ongoing, plans are virtually still right now out and about. We are the boots on the street, and we're partnering with stakeholders in communities across all counties to identify CBOs or community-based organizations at the local level to enhance and to build a network of local providers that are highly skilled and are subject matter experts in LTSS-like services. What's exciting is that what we've seen so far are local organizations like independent living centers, Area Agency on Aging, MSSP. They are stepping up in areas to support CalAIM areas such as enhanced care management and community supports. And some of those supports are, recuperative care, respite services, housing assistance programs, home modifications, meals are just a few of them. And then we're also rolling out incentive programs in partnership with other plans, and they are available and will become more available to local organizations and communities that want to increase and expand capacity. So we officially launched in January, which is just a couple months ago, and the time has flown by really fast. And yes, we still have some kinks to iron out, some more data to be shared, contracts to be completed. Local organizations, though, continue to step up all along the way and are very supportive and offering to help test these new processes under CalAIM, like referrals and communications and claims. And so we're very, thankful for the local support. Also very exciting is that we are hearing from local organizations that they want to learn more about how to expand and grow their services, not only within the current county they're serving, but to neighboring counties as well. And there's a lot of need out there, so we too appreciate that. So while we continue to implement ECM or enhanced care management and community supports over the coming years, we are also preparing for that 2023, which feels like sometimes tomorrow. We are preparing to have an expanded role in institutional long-term care, population health management, and lots of good things happening again, all in 2023. So to wrap up my short presentation, our end goals are, coordinated and streamlined services, to identify and to support incentive programs, to streamline data, and to continue to partner with you all at the local level, as well as with our statewide partners. So I appreciate the time to present here today. Thank you.
Great, thanks so much. Next, we have Anwar.
Well, thank you for including me in part of this panel. And like Selena, as a CBO perspective, we are also excited about CalAIM. And today I'll share some of my perspectives and share our experiences as of yet. I know CalAIM is fairly new, but we do have some great experience to share with this team. So we finally have a great plan that begins to focus on whole person interdisciplinary approach to comprehensive care management programs that is unique. It addresses both the clinical and non-clinical needs of our high cost and high acuity members. CalAIM is bold, like Bambi mentioned earlier. And you can see the evidence of that with all the resources that the state and the managed care health plans have been providing to not only providers, but also the community, including funding opportunities to increase the capacity and multiple resources and programs for those in needs. It aims to address any silos in order to close the gap of care and provide an integrated care service delivery. But there is still a lot of work to do. We still have to communicate with each other, share really the best practices on what's happening on the ground level to our colleagues at the managed care health plan, and of course the state. Work together to ensure the success of CalAIM. It's really important for us to continue our communication because we really want CalAIM to be successful. We want it to be a benefit for many years to come. We also need to work on integrating or involving other community-based service programs. Many of them don't really necessarily know what CalAIM is, so a bit more communication. So I'll speak a little bit more specific on the enhanced care management program. Partners has been a community-based service provider for many years. We have been providing the health homes program before the CalAIM initiative started, and what we can share is that we've already seen major benefits from the participants that we have served in ECM. So enhanced care management program takes the lessons learned and best practices from the health homes program and whole person care and created a new innovative benefit. Our preliminary lessons learned and current focus continues to be on successful engagement which is, I think, the key of our outreach efforts. This population, the focus folks that we are trying to engage have had so many lifelong trauma. They're upset. They don't really trust, and our job is to really make sure that they trust us and allow us to provide them the services that they also choose, and we could identify with them. This is accomplished through our assessment care plan process. We work with the member to identify health goals, medication management interventions, and ongoing comprehensive care management. We ensure participants share their goals, which is the most important to them, and again, key to keeping them engaged, because we can't really tell them what they we do tell them what they need, but we really need to hear from them and what are their goals and how we can help them accomplish those goals, those health goals. Even if they're not health goals, what are their life goals? Anything to keep them engaged. We then work with the participants and their network of care providers to identify other beneficial goals, and during the assessment and care planning process. Partners also not only works with the managed care organizations, but also any or all other providers related to the participants' care in order to address both the social determinants of health, but also make sure that we take the lead in coordinating any clinical and medical needs. So that includes working with the medical groups or the mental health specialists or the FQHCs, the hospitals, to transition them out and make sure that we reduce hospitalizations. And I'd like to end with some of our preliminary goals, and we're hoping to share more goals towards the end of our 6-month process, which is from January to July. We haven't noticed major improvements in the quality of chronic disease management, and just the participants understanding how their chronic disease is impacting their lives. Improved access to care was almost immediate. It's unfortunate to say, but many of these participants that we have been working with enhanced care management have not seen their primary physician for sometimes over a year. We've also noticed that those that have been enrolled with multiple ER use and hospitalizations almost immediately stop going to the hospital just because of a small intervention. Just being connected with somebody it has already improved their readmission rates. And of course, once you get them in and they trust you, we notice a major improvement on participant satisfaction. So, and I'll stop there just so that we can give other panelists some time. Thank you.
Great, thank you so much. And Jack, I will hand it off to you to wrap up our panel.
Awesome. Well, thank you all for the invitation. I'm happy to be here and to speak. Healthcare advocates, legal service providers generally, we're keenly aware of the multiple, varied, challenging social determinants of health that impact our consumers, their health, their stability, and their wellness. And so have been incredibly excited and invested in this CalAIM initiative and its ambitious effort to reframe healthcare need and spending, and by making significant investments in an effort to address those social determinants of health, and all from a patient-centered approach, which is as it should be, because all of these needs are so individual and unique to the consumer's perspective. In that same vein, I thought it would be helpful to kind of frame some of the developments here in the context of a case study, if you will, describing a consumer that I've worked with for years, and a consumer in both a pre-CalAIM context and a post-CalAIM context. And Yeah, so my consumer's name is not Deborah, but for today's purposes is Deborah. She's dual eligible on fee-for-service Medicare and in the Medi-Cal managed care plan. She has a long history of serious mental illness, both access 1 and access 2 diagnoses. And she has co-occurring physical health problems as well, pretty serious heart problems, arthritis, and other kind of typical ailments of someone in their, early 60s that hasn't maybe taken the best care of themselves over the years. She's been hospitalized multiple times, both in general acute hospital settings as well as in involuntary mental health holds and hospitalizations. And of late, due in part to her behavioral health problems, she's lost her housing. And she has a Section 8 subsidized housing voucher, which is so incredibly valuable in these days of incredibly unaffordable housing. But despite that, she's been unable to find a new unit. She's currently living in her car and is at risk of losing her voucher. So this setting, this description is a description of a consumer that I've worked with for years. This situation occurred about 1.5 years ago, so this is prior to the launch of CalAIM. And in that time, Deborah's managed care plan had little resources to support her in that period. Primary care physician was engaged, trying to refer her to local support services, the local 211 agency for other resources that they were not aware of. Member Services was trying to connect her with psychiatry appointments to ensure that she was maintaining meds. But each of these efforts were in a silo to some effect. They were largely limited or passive in that they were referrals that were handed to Deborah, and Deborah had to follow up on. And there was little to no coordination. So the different pieces that were trying to help her weren't engaged to help coordinate her efforts to remain stable and healthy. So in a scenario in which, had this happened in a scenario in which we have enhanced case management services and community supports as we do now, Deborah very likely would have been identified by her plan as someone that would have been eligible for ECM based on her recent hospitalizations, and that would have engaged those enhanced case management services from the start. Alternatively, her PCP, her primary care physician, or her psychiatrist could have referred her over to enhanced case management, or one of the many local service providers that she interacts with could have engaged her plan to ensure that she accessed enhanced case management and or community supports. And in that scenario where Deborah was engaged by enhanced case manager, those kind of wraparound and really tailored services would likely start with engaging the broad array of housing supports available under the community supports benefit, including a housing transition navigation services. So someone to get in there and help coordinate and identify resources in housing, be that second hand, if you will, to help communicate with Deborah, with prospective landlords, help Deborah through the application process, help communicate with her Section 8, make sure that she had an extension on her voucher given the extenuating circumstances. They also could have engaged housing deposit assistance, that one-time assistance to help Deborah cover first and last rent and get into a unit. And also, very importantly, I think what's really exciting under community supports are the housing tenancy and sustaining services. So often, folks like Deborah and clients, other clients that I work with, like Deborah, have difficulty maintaining stable housing because of, perhaps because of symptomology related with their mental health condition, or just difficult living situations. Maybe the landlord is not being fair to Deborah or others like her. The neighbors are maybe difficult, and these housing sustaining services can get in there and help coordinate communication with the landlord, provide some dispute resolution assistance, help identify for Deborah kind of where her part in prior problems in terms of communicating with landlords and or neighbors may have contributed to some of the instability she's faced. And so really kind of like a housing coach, someone to get in there and assist her. And so these are the services that I think we're very excited about seeing. And in this scenario, I've mostly talked about housing support services, but of course there's tons of post-hospitalization, respite, nursing facility transition, and diversion type services. These are all really incredibly important and come up in the context of our work on a regular basis. So we're very excited to see these. That case manager, enhanced case manager, would also be involved in making sure throughout this process, she's engaging her behavioral health and physical health services to make sure she's remaining stable, identifying and removing barriers that prevent that consistent access to treatment. For example, the transportation assistance, making sure that's coordinated with the plan, scheduling assistance, identifying needed providers, facilitating communication and overcoming barriers with providers. I think these are the things that the ECM will be incredible at ensuring that Deborah and others like her will avoid disruptions of care. So that's kind of a small snippet of how these community services, support services, and enhanced case management services could be engaged. Before I wrap up, I just want to highlight a couple of items that we in the consumer advocacy world will continue to watch out for with regards to this implementation, because this is such an incredible opportunity. We want to make sure it's implemented equitably, fairly, and as effectively as possible. So for one, we're really interested in seeing how the data sharing, integration, and coordination of enhanced care management services and community services, community supports providers coordinate with the rest of the broad array of Medi-Cal managed care plan, medical, mental health, sub-services, and the carved out, SMI, serious mentally ill, mental health services, the carved out substance use disorder services, dental services, and so on. Those pieces are incredibly important, and especially in this implementation phase, we'll make sure that those pieces are connecting and aren't operating in silos, and do our part to help flag instances where it's not. I think we're also really going to monitor how effective and meaningful the engagement of consumers is by ECM staff and the related subcontractors in the community supports world. These are, again, such valuable services. We want to make sure that there's no box checking, and that these are quality and effective engagement efforts made on behalf of subcontractors. We really do, in the consumer protections kind of world, we're going to, of course, monitor the appeals, grievance, and various due process rights of consumers as they receive these enhanced case management services and community supports. We are in one of those elements of consumer protection that we're watching is also the continuity of care protections for folks in enhanced case management and community supports. There are some continuity of care protections for folks that are transitioning from whole person care and health homes programs into ECM and community supports. And so we'll be monitoring how that is implemented over these initial 6 months in counties that have those existing programs. And we're really want to make sure that that the managed care plans exercise oversight over the subcontractors' delivery of these services, both enhanced case management and community supports, particularly in and around enforcing language access and cultural competency among subcontracted providers. We feel that's an incredibly important responsibility of managed care plans that can't be lost in translation as those duties and those services are subcontracted out. And so we want to make sure that those continue to be provided. I'll stop there. I'm sure there's lots of great thoughts and questions that may come up. I'm happy to be here, and I'll looking forward to the discussion. Thank you.
Great. Thanks so much to all of you. I'm going to take a moment here and just introduce quickly Sarah Steenhausen, who many of you are familiar with from her previous role, but she is now the Deputy Director of the Division of Aging Policy Research and Equity at the California Department of Aging. And Sarah, I think she put it in the chat as well, but maybe has some comments, and also just want to do a little plug for another webinar that might be useful to folks. So Sarah, I'll pass it to you real quickly. You're muted.
Thank you so much, Athena. It's great to see everyone, and what a wonderful conversation. I was sorry to miss the first part of it. I just wanted to note that, it's a perfect opportunity to continue this discussion on Wednesday. We are hosting our first webinar of the year related to the Master Plan for Aging, but specifically focusing on CalAIM and community supports, and how aging and disability partners, community partners, can leverage these opportunities to become community support providers. And we will be having a really great in-depth panel discussion led by Sarita Mohanty of the SCAN Foundation with partners from the aging and disability community, including Anwar and Eli Jalardin, Michael Costa from the Area Agencies on Aging. So again, it's really going to be looking at where are the opportunities and what are some next steps for consideration for aging and disability partners to move forward with this aspect of CalAIM. So I will put the link up in chat, but look forward to seeing you all there as well. So thanks for having this session, and look forward to talking to you all soon.
Great, thanks, Sarah. And we can also send out, I think there's been a few questions about the materials, and we'll send that out in the link. But see, Anastasia's back on, ready to be in the hot seat here. So we have some questions that have come in. So one of the questions was around extra funding for the counties as community supports and enhanced care management are rolled out. So I don't know if you want to just quickly, Bambi or Anastasia, hit on, how it's sort of envisioned for those funds to flow down to some of those community providers into the counties.
I think Bambi probably knows a lot more about that than I do.
I can't find you. Okay, Maria, I apologize. Can you repeat? I was trying to multitask. Can you repeat the question for me again, please?
Yeah, just about how will the counties get extra funding for implementing community supports and enhanced care management? Is there a direct flow, or does the money all go through the plans? I think there's sort of just wanting to better understand how the counties will receive for the support they may be providing, since those services are often provided at the local level.
Yeah, no, thank you for the question, and it's a good one, because there are two kind of funding opportunities. There's the CalAIM intensive program, and then there's also PATH dollars as well, with PATH kind of flowing through the plans, and then the other one going directly to providers. There is resource materials, and it's because it's very kind of detailed and specific in terms of like what needs to be in the plan in order to get payment. So if it makes sense to you, I would like to grab some of those materials and share it out with this group, and then see if that kind of helps respond to some of the questions, because we do get that a lot, and it's kind of decouple it. So yeah, we'd be happy to share that.
Great, thank you so much. So another question that came in was just about respite services and a little bit more detail about how someone gets assessed for respite services, how the hours are determined, and how you can advocate for getting access to those services. So if someone feels they need it or know someone who needs it, how would they kind of go about accessing those respite services?
Okay, I can take that one. So the respite services is one of the pre-approved community supports, and so then it's a current plan benefit today, and so as part of ECM, the ECM provider would then be identifying and assessing members who would be eligible for such type of services. There is, because I'm seeing the question, there is a cap or a limit on the number of hours. I can't think of it at the top of my head, but in the community support policy guide, I believe that is in there. And so I will grab that and send that as well.
Okay. Sounds like we'll be sending out lots of links to everyone for more information. Again, it's very,
Yeah.
yes, it's very difficult to cover it all in this time. It looks like there's a follow-up to that question, is more about how do they advocate with the Department of Healthcare Services for future contracts to include enhanced services such as, you know, not just respite care, but things like financial support, legal support, some of the stuff maybe that Jack hit on, folks needing assistance with.
Yeah, I think I think Dana is I think she's on the line and wanted to provide some additional context to what I just provided. So if she's able to
Great.
add, that would be helpful.
Yes, I see her, and it looks like there she is. Go ahead, Dana.
Great. So, you know, as you can advocate for your members or the people you're working with, it's a great question. If you feel like they're appropriate for a community support that's offered, please refer them to the managed care plan, and they each have a way of assessing people. Most of them are following the service outline that is in the CalAIM guide. If they're deviating from that, that information will be on their website of populations who are not eligible for a certain community support as they're growing it. But ECM should be very easy to get someone to be assessed for it. It may take a little bit longer with community supports as we continue to grow in that area. But we really are excited about both of them, and we want the right people to get the right services. So if you have anyone that you feel is appropriate, please work with your managed care plan. And if you're having trouble with that, if you'll send an email into the CalAIM inbox, then we certainly will work to make sure that you know how to do that appropriately.
Great, thank you so much. So following that, there was a comment that it might be helpful, you know, what you said there about sort of who's eligible. There's a comment that it might be helpful to have a grid that shows who's eligible for enhanced care management, since we know it's really targeting, you know, a small percentage of sort of the top high utilizers and folks that really are identified as needing those services. So just a request there, no need to respond on site whether you're going to get that or not.
I think that the resource, it's a great question too, Athena. We do have on our website several PowerPoints that really cover that information pretty well. And, you know, we're not really stuck to that 1 to 3%. We want the right people. So there is a risk corridor that would allow people to be assessed for it who actually need it. So don't feel like you shouldn't refer someone because they may not be in that 1 to 3%, but they may be more appropriate for a different type of care coordination, and or they may be in that 1 to 3% may not be right. The goal is to give people the right care at the right time and help them to connect in the way that's appropriate. So don't ever be afraid to refer someone because you're worried about that. But I would say if you look at the ECM program guide and the slides that are online, they'll tell you what the definitions for the population of focus are. And if one of the people with whom you're working is in that population of focus, they really should be referred for ECM.
Great, thanks. Really good point about sort of catching those people that maybe aren't always on the radar because of utilization, but might also benefit. So really appreciate that clarification. So one last question, and then I want to also see if our panel has anything to add, but there was a question about provider networks and really making sure that there is broad networks that provide access to what are often very complicated patients, and that maybe there is some resistance to providers to sometimes taking on, you know, some of these more complicated and complex patients. So just maybe some information from the department about how you intend to kind of provide, you know, oversight and ensure that those networks are made available to folks. Anastasia or Bambi, one of you who's in the hot seat this time.
Well, we have our money follows the person roadmap, which I think will help contribute to this work. I don't know, Bambi, if you have other thoughts. Were you guys able to hear me?
You're breaking up a little bit. Yeah,
A
you're
little,
kind of an echo.
I
Yeah.
was breaking up a
Okay.
bit. I think what we would say is that we do acknowledge and realize that this could be new relationships for a lot of the managed care plans to be working with community-based organizations. And so we're working with them through when they submit their model of care to the department, which is kind of how, like, their framework on how they intend to provide the services, what kinds of providers that they're going to be working with, whether currently engaged now or kind of what their future engagement will be. And we are working with the plans, like, through that process, because we want them to be successful. And so, as a state entity, I think, one of the things we can do is remove any barriers and kind of help in that space, and provide kind of collaborative learnings and things of that nature. But we do work with them on through their model of care, and are also, as Jack had mentioned, working with them on just kind of monitoring how the benefit has implemented for the first round. And so just watching that as well.
Great. So I think I'll jump to the panel, and maybe I'll start with Selena, since that was a health plan related question, and just sort of your thoughts on expanding networks, new provider types, some of the opportunities and challenges from your perspective.
Yes. It's been some good work reaching out to our counties, and how we started doing that was identifying stakeholders first to come to the table and share with us what services do county agencies, right, like our county behavioral health departments, public health departments, and so on, as well as who are the local CBOs that are doing some of these community supports, already providing ECM-like services that would be interested. And so that was really our starting point, and meeting with each county, and then every 2 weeks, every month, whatever that determination was, by the county. So we looked to them to take the lead and share with us. So that's really how we looked at our network. And then now we're in a place to sort of take a step back and analyze what the network looks like, as well as, so if we identify a county, often there are smaller rural counties that may not have all of the resources that we need to implement a community supports. So we're looking at our neighboring counties and the providers within those neighboring counties and asking, would you consider, is there a relationship already there? How can we help you increase capacity? And then, as well as working, we have an ECM clinical support team that are working one-on-one with the existing contracted providers, and providing some training and learning opportunities around trauma-informed care. What does education and outreach truly mean, and motivational interviewing? So that work continues, and it will over the next couple years, 2-3 years.
Great, thank you. I'm going to jump to Anwar, sort of follow up on that from your perspective, as having worked with a lot of plans and been a provider and working with lots of various providers. What's your perspective on how this is done effectively?
Well, I think what we're doing now is really good in terms of communicating our CalAIM programs and services to other providers. Again, there's so many providers out there, including some of my colleagues, that have really no knowledge of what CalAIM is and does and how they can participate. So I've been getting a lot of phone calls from some of my colleagues and asking me how to participate in CalAIM. And I will be sharing more of that type of model in Wednesday's webinar that Sarah will be hosting. But I think one of the key here is to continue the communication to all stakeholders, including hospitals. How can they refer? How can they coordinate with us? the medical groups and just all sorts of diverse providers. I mean, you've got a really good diverse pool. We got community-based organizations such as Partners in Care, which really addresses the social and the clinical. You've got wonderful FQHCs that are doing this work and providing clinical based services and social. One way that Partners has identified to resolve or attempt to resolve the capacity issue is really looking at those areas that are underserved. And like Selena said, some of these CBOs don't have the qualifications or credentials to participate in a contract with managed care. So Partners in Care were being NCQ accredited, developed an ECM network so that we could help other CBOs in specialty areas that really know that community, know that the resources in that community, to engage them through our network to provide ECM services through a delegated model. So that's one approach that we've been helping the state and the health plans to address the capacity.
That's really great. Thanks. And following that thread, Jack, I want to hit on something you said at the end about, sort of meeting people, where they are, their culture, their language, and making sure that happens. So what's your thought on sort of not just robust networks, but networks that actually reflect, the population and can provide the services they need?
Yeah, no, it's a particular importance and also concern, I think, in the variety of wonderful pilots and projects we've seen. We've seen that sometimes subcontractors are new to the Medi-Cal environment. They're not used to the rigors of the data reporting, the training requirements, and it becomes a challenge for the plan to ensure compliance and ongoing compliance with those requirements. And that's really important. That's where the rubber meets the road with these services. And so for those front-facing services to be culturally competent and engaging consumers in a way that is inviting and not off-putting to those consumers is absolutely vital. Those are the transaction points where credibility and trust are lost within sometimes initial conversations. And so to the extent that those folks are not trained, it could be a disastrous unless they are trained. And we assume they all will be trained, and we are certainly inviting the department to continue to be exercise great oversight over that. I think also as people change, another thing to kind of watch out for is people change their managed care enrollment, how they move between ECM and community supports networks or providers of those managed care plans will be a particular interest and concern. To the extent that networks overlap, great. To the extent they don't overlap, to what extent will continuity of care be maintained, and data sharing to ensure that the benefit of the prior work can be sustained and also continued. All of these things are really, really important aspects I think need to continue to be discussed and worked out. So happy to be part of that conversation and work with partners on developing those approaches.
Great, thanks, Jack. I'll just wrap up with Tiffany. Just come back to you and sort of the same question about, Justice and Aging does a lot of resources for people that assist beneficiaries, and specifically thinking about the duals population and how they utilize these benefits sort of in collaboration with their Medicare benefits. Any thoughts you have about how those will interact and what will help the member?
I think just touching on a lot of the points that others have mentioned, like especially with enhanced care management or community supports, they're really, vital services that have a lot of potential to really help people. And, part of their potential is really, are they being utilized to their full potential? Are people getting access to these really critical services? Are they available in the county and rural counties? So I think the pieces of, one, making sure that plans are, providing education to their community-based providers in the county, to, whoever it is within the spectrum is aware that these are services that they can offer. So helping make sure that people are actually identified are key. And I think with, DHCS or with the Medi-Cal plans, really monitoring who actually is getting those services and the makeup of the individuals that are receiving those services. Are they equitable? Are people of all races or languages being able to be connected to these type of services? So I think that's really important. And I think part to touch on, I guess, on duals that have Medicare and Medi-Cal. Another piece is, how do we reach those that are part of a Medi-Cal plan, but not are part of a DSNP? So are they also being reached? Is this population who does not transition into these exclusively aligned DSNPs? So they also utilizing the services that CalAIM is really meant to provide to make sure that, California or Medi-Cal beneficiaries as a whole are really able to reap, the really transformative pieces that CalAIM can provide.
Great, thank you so much. It's a lot to cover, but thank you so much to all of you for being as concise as possible. Encourage you to join that CDA webinar tomorrow to continue the conversation, and I will pass it back to Maria from the collaborative to wrap us up. Still on mute, Maria.
Still on mute.
Oh, there you go. Someday we won't have to say that anymore, right?
I know, maybe soon. I just want to say a quick thank you for all of our panelists who joined today. It was such a great conversation, and I'm still in learning mode about CalAIM, so this has been really beneficial to me in a very selfish way. And Anastasia and Bambi, thank you both so much for taking the time, not only engaging with the collaborative today, but over the past months and months having those conversations. And it really does feel like we're all working towards this amazing goal and making CalAIM really work in our communities in California. And we just really appreciate your time, and of course the Manna team and others who are on today. And with that, I hope everybody enjoys the rest of their week, and we will be sending out a recording of this webinar. We'll send out the slides, and lots of links were shared in the chat, so we'll pull those together and synthesize them, make sure they go out in the email as well. And before I log, I'm going to one more time drop that link to the Department of Aging's webinar on Wednesday for those who want to continue to engage on CalAIM and continue to learn. That's there. I do encourage you to register to have that conversation, and we'll see you next time. Thank you so much.
Thanks, everyone.